Very good evening to everyone here. On behalf of the Departments of Pathology and Department of Medicine, I welcome you all to today's Clinical Pathological Conference, where we have with us as the clinical discussant, Professor Narinder Singh, Dean Research, Eternal University, Himachal Pradesh, India. Served as a clinician with many decades of experience and has a special interest in nephrology. He is a fellow of the International Society of Hypertension and many other societies, and has received multiple awards and has more than 150 publications to its credit. And despite his adverse circumstances in the recent days, he has taken great effort to be here physically with us to participate in this learning experience. We are very grateful for that, sir. Thank you for being here. Good evening.
It's always a great honor and privilege to come to the prestigious All India Institute of Medical Science. That too in this forum, where I had the luck of having come 3 times earlier. So this is my 4th innings. First time when I came, I had what is known as academic approach. Right? I was the boss in MMC and I was actually driving the academics. So my slides also reflected. Second time when I came, then I had the financial influence. I was the head of Max and I had a lot of publications and that too in medicine along with the lead. So now I am in a place which is known as Sirwar district. So that should espouse simplicity approach. So you always prime up and you have to come down. I know one of our very greatest friends has just stepped down, and I'm very sure he will accept it humbly and he will be looking forward to the most important journey of our lives when you try to talk to the community. So the place where I am in is a university which is in the remote area of Himachal, and we just talk about the community problems. And just the day before, when I was trying to figure out how to prepare my slides, and I was trying to figure out the clues, there was a cloud burst. And that was my first experience. In my front, this thing, only the room got flooded. Somehow we came out, but the system did not come out. So I had no choice but to prepare the slides today morning when I was sitting and waiting for one of my volunteer girls to give an exam. So in the car, I prepared the slides. I'm very sure this will reflect. And of course, CPC, again, earlier when I was a person, I said one always wanted to reach a diagnosis. Somehow pata chal jaye, by hook or by crook. I know many ways and means of trying to figure out. But now it's very clear that it's basically a learning tool. If you go through the Google and you find out this used to be all the very learning tools, and now I'm trying to de-learn things. So I'll make it very simple. I'm not going to give you the very flamboyant diagnosis. I'll try to figure out how I would approach. Please understand that this case took 1 month, full 1 month, and 5 biopsies to come to a CPC. So you can understand the intricacies which our colleagues have gone through that. And so I'll just... so we have... so I spent around 10-15 minutes on the presentation, and whatever is in red is an important activity and whatever is in blue is an excluding activity. So we have a very young male who's a student and unmarried, has to be unmarried at 20. Normally they get married now at 30. No prior comorbidities, and again a very surprising no addictions. Complained of pain, redness and swelling of both lower limbs for the past 20 days. This was when he presented to the present hospital. And he also complained of pain, redness and swelling of both the upper limbs for 10 days. And this is classical triad. You understand when you have pain, redness and swelling, talk of inflammation. He did also have pain and nodular swelling in the forehead. So story goes back to around COVID era in 2021 when he developed a frictional trauma. Again, what I learned is that these, now I'm doing one more course, I'm a student now in geriatrics. So one of our orthopedic teachers told us that this friction and all of these are just small activities with which the patients normally relate you to the symptoms, the major symptoms. So he developed a painful blister and he took an oral medication which was healed with hyperpigmentation. 5 days later, again he noticed 3 or 4 blisters of the same area. So essentially a dermatological problem as of now, and he went to the local hospital and same result. He was able to walk, play, and do his activities normally. I don't know whether we really play at the age of 20 nowadays. 80% of our time is spent on mobile playing. Do activities normally without any support. So you don't need much support in that. So again in March, the story started at the end of November. In March, he started noticing redness, pain, and swelling. So these are coming again and again. These are certain points which I would like the students to remember. And lateral manual of the right leg, which spread over calf in the next week. So this was a different type of a pain and swelling, which is spread to the calf. Third week of March, he developed similar complaints in the left calf. So it's like what is known as fleeting activities. So occurring in one leg, then going to the other half. Now he was requiring some support to walk. And especially he developed similar complaints in the upper limb. This is a very, very serious thing when you develop a pain, swelling spontaneously in the upper limb. If it is thrombophlebitis, then we have to think in terms of some secondary cause. Patient was admitted in a hospital and where he was given treatment, and this is the standard practice. 90% of the subjects in maths always receive one course of antibiotic, irrespective of where they have come. So antibiotics are the in thing, and especially when you will have one investigation that I tell you. The patient developed swelling over forehead, followed by the right cheek. There was a history of weight loss. Now, weight loss of appetite, this has to be significant. A young male developing a weight loss and appetite talks about chronic issues. Because of the pain, his activities were restricted and he was confined to bed. Now, this is an important thing. He started having difficulty in walking with a history of weakness while getting up from sitting position, obviously indicating a proximal sort of a muscle involvement. There was no history of difficulty in buttoning shirt, eating food, raising hands from the bed, difficulty in breathing or difficulty in swallowing, suggesting that there was no distal involvement or there was no so-called cranial involvement, or if you talk about myositis, then probably swallowing is not affected. There was no history of tremors, posterior instability, bradykinesia, suggesting a central nervous cerebellar involvement or a neck stiffness, impotence, and syncope. Now, the patient denied any history of fever. Please understand, one of the important presentation in any medical parlance is fever, and this person did not have fever. He had no constipation, diarrhea. It's a very common presentation of elderlies in India. Abdominal pain, micturition, jaundice, altered sense. No jaundice. Again, a point to be noted. So that's why I highlighted it blue. Well, he did not have any cranial nerve involvement, so there was no decrease in vision, diplopia, altered sensation, deviation of mouth, deglutition, struggling also. In the hospital, the patient developed swelling, which were red, nodular, and some of the swellings developed into ulcers. Now, this is one event which has occurred. The swellings which were there earlier have now eroded and have become ulcerative lesions. Again, generally a dermatological issue. So this was the history which has been given, and examination, again a very elaborate examination by a good resident of All India Institute, cautious, cooperative, plays in person, moderately built. I don't know, his weight was 50 kilograms. Will he be moderately built? BMI should have been given, but I think probably he must have been lean and thin. I really don't want to show you the photograph, but he was not moderately built. There was no pallor. Again, a very important thing. Any chronic issues will bring about a pallor, icterus, cyanosis, or clubbing. He had inguinal lymph nodes, but 1 centimeter into 1 centimeter, firm, non-tender, and mobile. May be important clue if you talk about the differential diagnosis. When the bilateral upper lower limbs showed diffuse inflammatory changes in redness and tenderness. It could be cellulitis, it could be an underlying muscle disease as well. Forehead also had a nodular swelling which was described, and it was tender, mobile, and a pus point was coming out of it. The right cheek also had the swelling. So there were a lot of subcutaneous swellings, and they were all red, they were tender, and they were mobile. Patient had a borderline heart rate, 100 is okay, regular rhythm, all peripheral process. Again, a very important thing when you talk in terms of something to do with vascular disease. He was not tachypneic and he was not using any accessory muscles. Now look at the person, 50 kilogram, and All India Institute resident is writing one reading of 144 over 94 and 140 over 90 in the right left upper limb. I'm very sure you know the definition of hypertension. You have to have at least 2 or 3 readings to say that this patient has hypertension. So this patient is only having a higher blood pressure. No further readings were given to me. It was 160 by 90 and 160 over 100 in the low limbs. We expect some higher readings in the low limbs, but definitely, by definition, he has a high blood pressure for his age and his for weight, but definitely no further, and he was asymptomatic. CNS examination, mental functions were normal, motor and sensory, of course, the patient had pain and tenderness, so it's difficult to do a motor system, and we need to be very clear, be transparent. Whenever in the exam you have a case like this, say that patient having been sick, patient's comfort is the most important thing, so we did not do a detailed examination. However, patient was able to move all his limbs and reflexes were normal. This occurs in two situations, and this I, as a teacher, witnessed this. One is when you have actually tested it and you could not find it. In a person who is having so much of pain and swelling, whether you tested it or not. Second is you don't test it, you say, sir, looks normal. You're very sure. So I don't know which one was it as far as residents were concerned, but other systems were normal. This is important for a multi-system disorder. We need to do a thorough chest examination to look for a bilateral crackles in the lower zones, or you look for a nose and murmur, which could contribute. But however, this patient, young patient who came with dermatological issues or some joint issues, did not have a system. Investigations, 11.2 grams. Fairly okay for an Indian standard. Leukocytosis, 37,000, and no fever, mind you. Patient was given intravenous antibiotics, but a leukocytosis. This is important. Fairly borderline high thrombocytosis. Renal functions, again in multi-system, always look for a good urine examination. Did you give it to me? No urine examination was given anyway. But renal functions were fairly okay for his age. 0.5 will convert to around 110 eGFR, which is fairly okay for his age. Electrolytes, again important entities in muscle disease. Hypokalemia can be one of the presentation and can contribute to myopathy, but normal. Bilirubin 1.3, but OT, PT, SC, ALT and AST were normal. And that's very important because many of this may also reflect a muscle enzyme. And indirectly, many a time we've seen a patient where the patient actually has muscle involvement, but the OT, PT was raised. Proteins were fairly normal. Urine, yes, given. Examination was normal. We should describe it in a multi-system disorder. Again, an important thing, hepatitis B, C was negative. Inflammatory markers, both. Now, this has become a very, very important thing in the COVID and post-COVID area. ESR and CRP were high. And so was LDH. LDH is again an important marker for you to contribute, whether it is hemolytic anemia or whether it is muscle injury. This is the important thing. And ferritin, again, a very good inflammatory marker, not markedly increased. It is not one of those situations where you have a hyperferritinemia and the diagnosis comes also with still disease with 37,000. That's also a CPC. But here it is not there. During the course, no significant change except TLC now brought to normal. In 6 weeks, it took 6 weeks. No infection will take so much time to bring down the normal. Well, bacterial workup, multiple blood cultures sterile, blood cultures for anaerobe negative, leptospira IgM. That's why I made it red. It was positive, but when they did a PCR, much more sensitive, was negative. Right? IgM antibodies for scrub typhus, again a very important place where I stay in Himachal. A lot of subjects do come to us with multi-system and they turn out to be scrub typhus. So we need to rule that out, which is negative, especially if the patient has jaundice. Brucella, again a very important entity. We've done one CPC with that. VDRL negative, serum for Lyme serology, very good. So a lot of investigation for infections has been done, except for one, which also partly gave a positive response. There was not much positive response. And then nowadays, of course, a huge fungal workup is done. So Galector-Mannan, normal, cryptococcal, negative, CMV. Again, one more important thing, CMV positivity means what? There are only two things. All of us probably get a asymptomatic CMV infection and develop an IgG antibodies. So if you get an IgM positive, either you had an acute infection, wherein immunocompromised, fever, lymphadenopathy, some symptoms like herpes. Second is reactivation, and that occurs in generally in immunocompromised. But his status of immunocompromised state was normal. I think HIV and other things were normal. And then they did an immunological profile, very standard, both ELISA as well as IF, which were negative. Again, a very, very important differential in a patient with multi-system disorder. ENA, extractable nuclear analysis. Normally we do ANA first, but anyway they did an ENA which was negative, which tells us about the whole gamut of extractable nuclear antigen, and they were all found to be negative. Myositis panel, fairly costly thing, but maybe it is available in AIIMS. So they did it because the patient had muscle involvement. So all these, and I did have some knowledge about all this, and they all, including TIFI, which is associated with the malignancy and dermatomyositis, all were found to NT-Jo, La, Ra, Rho, PL. They were all negative. I understand that this is really a reliable test, and which is being found to be normal. Tumor markers, again, a weight loss, young male, dermatological changes. So we need to do tumor markers. All CA 125, they were all found to be normal. Even, yes, there is a bimodal peak of multiple myeloma, but this was also normal. Though patient did not have any calcium issues and anything. Serum for AC level, again, important was the borderline 40. So it's all okay. So most of the investigations done in the AIIMS or wherever have been found to be normal, except for leukocytosis. And then, of course, the patient had predominantly normocytic cells with occasional microcytes. The hemoglobin was fairly okay, and patient had neutrophilic leukocytes. And normally in practice, I know if this patient comes to you in practice, 99% of us will start the patient on antibiotics irrespective of fever. Now this is significant, superficial thrombophlebitis. Now they said upper limbs. What is SSV? I thought it was small saphenous vein. I don't know whether it's upper limb or lower limb, but lower limb mein hoti hai saphenous. So short saphenous. So it is mentioned in the upper limbs, but anyway, cephalic veins with thrombosis. So there was a definite evidence of superficial thrombophlebitis both in the lower limbs and the upper limbs. That's significant. Subcutaneous edema and arterial Doppler was normal. A left knee showed a significant synovial thickening. Some amount of synovitis is there, and left knee they said very reactive. Now here comes PET CT. Now PET CT, I don't know how it is reported here, but to me it was given in a different way. So focal uptake noted in the right cheek, skin and subcutaneous. Good. Subcutaneous fat standing with mild FDG uptake in the bilateral upper and lower limbs and shoulder region. Increased uptake along the muscles, tendon sheath, and diffusely increased uptake noted in the ST. So no other organs mentioned. कोई spleen में है नहीं है क्या पता spleen नहीं हो मतलब no organ details were mentioned. I understand probably they were not significant. That is what I presume, right? But normally we give a detailed report of this. Again, a CHC, क्या लिखा है? Chest and abdomen. And what is the report? Subcutaneous tissue, heterogeneity and fluid in all the 4 limbs, chest and abdomen, cellulitis, intramuscular ill-defined hypodensities, myositis. Ultrasound made a diagnosis of myositis. So see chest, abdomen. नहीं दिया गया. Anyway, I was supposed to see, but I could not have time. So 2D echo, yes, very good, normal. And I told you about those reflexes. Sensory motor polyneuropathy involving all the 4 limbs, likely axon. So please understand normal reflexes, but axonal neuron. Renal Doppler, again a very important norm. So PET CT done again. 34. It was done earlier, around 4 weeks back. They have done it again. Why? They were not sure of the diagnosis. They said that compared to the previous scan, there is an increase in the extent of muscle involvement. Hypermetabolism, bilateral thigh muscles. Again, only the muscles being talked about. And despite of intravenous antibiotics outside, inside, the muscle metabolism seems to be not bothered about antibiotics. So, again a CT angiography, no mention of anything except aneurysm nahi hai. Okay. So here comes 1, 2, 3, 4, 5 biopsies. Over a spread of 1 month. तो अगर मेरी diagnosis गलत भी हो जाएगी तो don't worry. ठीक है? So finally, you look at the timings. Obviously, biopsy from cheek swelling may not have given them the diagnosis. Skin biopsy again may have contributed. Bone marrow. This is interesting. Now liver biopsy. I just want the residents to know about liver biopsy. What I have learned is if the alkaline phosphatase is raised, then you might find some yield, whether it's lymphoma or tuberculosis or sarcoid. But if there's no fever, no alkaline phosphatase increase, LFT is totally normal. Doing a liver biopsy is only if you want to confirm something which you have already made. The yield is only when you have the percentage of yield becomes better. I don't know, sir, आप बताइएगा बाद में. Muscle biopsy finally, same day they did liver as well as muscle because एक week पहले bone marrow में नहीं मिला होगा या कुछ ऐसा मिला होगा कि वो नहीं मिला होगा तो so finally they did a muscle. So this is in short about the presentation. There are certain things which I would like them to be highlighted. We had a skin lesion. We all have read a lot. Muscle involvement probably looked like a proximal. Superficial thrombophlebitis, both upper and lower limbs. Joint effusion, at least one knee they have demonstrated. And neuropathy, blood pressure reading. Now I just put a query because one reading only. They did not make a diagnosis of hypertension. Patient had leukocytosis, inflammatory markers. Others, loss of appetite and weight. Now, next set of slides are going to be very simple. I did not have time. I had made elaborate, theoretical slides, but I thought I'll just do. First, let's talk about skin lesion. The patient had nodular skin lesion. Patient had ulcerated. Some of them are ulcerated. So here we have painful nodular lesion converted to ulcer, and many of them healed with hypertension. So what are the common causes? We have venous hypertension. We can have peripheral arterial disease. We can have diabetic foot ulcerations, but more important, this cutaneous necrosis will occur when there is a compromise in the blood flow, either because of the decrease in the blood supply or there is some amount of thickening or vessel wall is involved, and then we have a group of connective tissue and dermatological condition, all can give rise to ulceration. So we have, things like neurogenic, neuropathic disease, malignancy, metabolic, infections, iatrogenics, factitious. There are people who come to us. I had one case where they had multiple ulcers, but it turned out to be that he was smart enough. Well, we know connective tissue disorders. SLE is known to have classical presentation. Rheumatoid arthritis can present. Dermatomyositis, we'll talk about it. Systemic sclerosis, Sjogren's and Behçet's. Behçet's comes both in this as well as the next set of slides. We had inflammatory nodules. Whenever you have inflammatory nodules in the leg, we always talk about erythema induratum. This is more associated with tubercular lesion. Erythema nodosum like lesions in Behçet's. We have some thrombophlebitis, and we can also have cutaneous span. So these are some of the differential diagnoses. I'm not going to bore you with the theory, but what I want you to do is to empower you with these lesions. They are more anteriorly, they are more posteriorly, they are there in the lower extremity, and some of these causes which we need to investigate this patient fit. Of course, adoption of purpura should not be missed on dermatological examination, and then there are certain other conditions. More importantly, so we'll come back to that skin lesions. We had myositis causes. At least second symptom was what the patient had, and we have a lot of dermatomyositis, polymyositis, immune-mediated necrotizing myopathy. Now there are eosinophilic myositis and this term sarcoid myositis. Sarcoid is one thing which can occur. Sarcoid, tuberculosis, and now COVID can present in any way. So, and then we can have viral myositis, Coxsackie B, rhabdomyolysis, eosinophilic cystic fibrosis, trichinosis can present basically with myositis. Then statins, and one more important is trauma. There are certain drugs which can cause myositis, and please understand these are very, very important cause. I just came to know that azithromycin, I am a dyslipidemic patient, so I take a torostatin. But if you take azithromycin, which is again a very common thing for URI, there is a huge drug interaction. So please, as a resident, I would like you to ask a person what drug is he taking, look at your app and look for any drug to drug. Short of having a clinical pharmacologist who should be there in such hospitals like AIIMS, but if you are not there, you are the clinical pharmacologist and a resident and a wheelchair puller, one and all. So inflammatory myositis, again a very important thing. We know these are dermatomyositis, polymyositis, skin involvement, especially myositis, Newark syndromes, antisynthetase syndrome, sweet syndrome. I read during my presentation, including body myositis. So this is again a very, very important slide where they can present with acute, subacute, chronic. But I'm not going into details. All the markers which were done and shown here were negative. So I understand that probably they must have thought about it, and these markers, and they do signify that. Like as I said, TIF means malignancy is common, and similarly in XP2, malignancy can be common. So based on then, patient can have ILD, patient can have association. So all this myositis, vasculitis, connective tissue, sarcoid, they all mixed. You will find all sort of reports, especially Google RT will tell you everything. So the CPC, which used to be simpler, has become more complicated for a discussion because of plethora of investments. But more important, skin manifestation myositis. We have classical Gottron sign. Did the patient have hair? Probably not. Scholz and Wies sign, Raynaud's phenomena, and these will then display scars, and opening of the mouth can be impaired. And this is what these signs are, skin dermatitis. But our patient did not have these. Our patient had different sets of presentation. So, though dermatomyositis is one of the very important investigation, differential diagnosis, but it's at the back. Imaging, again a very important slide for you to understand. Ultrasound has become one of the very important imaging for myositis, which was done. But after that they say MRI is currently the best modality. Somehow that the MRI was not done here. अब क्यों नहीं हुआ पता नहीं, maybe ये कई बार खराब हो जाती machine. But MRI should have been done in this patient, but they thought of trying to find out the etiology. So that is why they relied on heat PET, doing it again, so that they could reach it, but finally they could not get any diagnosis. But for residents, MRI is currently better to model to evaluate the skeletal muscle. However, if you want to do a functional analysis, then of course PET CT should be done. Malignancy and myositis, again a very common association, but solid organs. Now here PET has helped. All these chest and abdomen, though report was not given, I understand that there was no abnormal lumps or a diagnosis of malignancy. Third is thrombophlebitis. What are the risk factors for thrombophlebitis? Of course, surgeons are sitting here, so recent surgery, prolonged immunization. Now we have a dictum in maths of, every person gets you have a scoring, and if the patient is moderate or high risk, Clexane is given, irrespective of what we do. Phlebitis also occurs in vasculitis, polyarteritis nodosa, right? This is the important thing. Now this again I learned, levamisole induced vasculopathy. Again, Burgess we all know, but our person fortunately was non-smoker and he did not have pregnancy. He could not have pregnancy. So, classification of neutrophils. One more important thing, just before I come to the slides, I have 10 minutes more. So, this is a very important thing for the residents to understand. Infection is one of them, but inflammation, vasculitis, non-hematological malignancy can all present. I had a patient who had a classical alcoholic hepatitis, but had a leukocytis, and there are people who can have no fever, but just leukocytis. So we need to try to look at things like steroid, left, right, and center, recombinant GCSF, GMCSF, cigarette smoking. I never knew that, but cigarette smoking se bhi mentioned hai, up to date wala hai, which is quite alive. Stress, of course. So please understand that this person had neutrophilia, but apart from infection, there are some other causes. Now I talk about reflexes and peripheral neuropathy. If that is true, that reflexes were normal and the patient had peripheral neuropathy, then you think in these two terms, Hansen's and amyloidosis. This is a classical exam. I'm very sure our seniors who are my students and now they are professors will ask these questions. What are the causes of this connective tissue disorder, lymphoma, diabetes, and vasculitis? So this is again an important entity to consider. I always say that resident is always right. So he did check the reflexes, but they were normal. So missing links, blood pressure recording. Please do it regularly. Not one reading in a 20-year-old who had a reading of 160 over 100. CPK, wow, muscle का केस है, सब कुछ ले दिया, CPK नहीं दिया. तो शायद छुपा लो. CT chest abdomen and chest CT में August ले दिया. It doesn't matter. रख लो अपने पास. We try to fix it up. So what is my differential diagnosis? My differential diagnosis is infection. Always think of first. Patient received antibiotic, both acute and chronic. It could be a non-infectious inflammatory disorders like SARPER. It could be an inflammatory so-called immunological myositis. Could be a connective tissue, malignancy, and then vascular. These are some of the different diagnoses which I think we should think of. I'm just making it very swift. Infections, acute suppurative, pyomyositis. Again, a very important. I had one patient came to us with acute kidney injury, and this patient turned out to be one of the rarest form of myonecrosis. And I gave a CPC to Sandeep. He could not make a diagnosis, and it was myonecrosis and then AKI. He focused on AKI without looking at it. And this biopsy report I got after the patient succumbed, and then we converted into CPC. So we should leptospira. We did talk about that. Conjunctival sufficient is one of the hallmark. Apart from dengue, which has come now, leptospira will always have young males, conjunctival sufficient. The place where I am in, there's a lot of slush now. So there you can have an outbreak of Pakistan where they had floods or here. Tuberculous myositis. PGI Chandigarh described in 2021 one case of tubercular myositis, but he had other ways. Of course, chronic fungal, Kala Azar, all were negative. Patient had CMV, which was positive, but I was told HIV, HPV were negative, so we will just keep it as such. Leptospirosis, I told you, classical eye, jaundice with suffusion, and of course this patient can have interstitial nephritis, they can have splenomegaly. Leukocytosis is one condition which can have peritoneal lefty with leukocytosis, leptospirosis. So you need to think in those terms. And Hansen's, always dermatological, neurological condition. Hansen's is one of the important things, and there are two types. You can see the nerve involvement. There was no mention of nerve thickening, so I understand that there was no nerve thickening, and there was a skin lesion which are described both in lepromatous and tuberculosis. Inflammatory myositis, we've already discussed about it. Muscle involvement, skin lesion, all muscle markers were negative. Thrombophlebitis can occur, but it's not a very common feature. So I would keep that also as a lower down, especially with the fact that patient, we always have one molecule which can cure all these, and I'm very sure it must have been treated here also, which is known as Raman. You know that. So all these conditions can be treated. So treatment is not an issue. The issue is the diagnosis. So sarcoidosis, again, a large lymph node this patient did have, but PET-CT did not show hyaline lymphadenopathy or was not shown. So I understand that could be one of the situations. Fatigue, weight loss was there in both the patient. Rashes, erythema nodosum, lung, persistent diaphragm, his chest was clear. Heart, echo, at least the full this thing was normal. Liver and spleen, not shown. Joint, yes, involved. So one of the possibility was eye involvement. It's extremely, again here, officially, I was not, did you see the protocol? No eye checkup was shown in this, which is again a very, very important thing to do. But I was told later that eye examination was normal. Musculoskeletal manifestation of sarcoidosis. Sorry for the slide, but more important is sarcoidosis can also involve muscles, leading to different pathologies, primarily categorized according to the clinical presentation. So one important thing you must think is in terms of sarcoid, acute myositis, chronic myopathy, and nodal myopathy. These are three types of sarcoid which can occur if there is a muscle involvement, and this patient can have fatigue, fever, joint pains, erythema nodosum. So one important consideration, and liver biopsy and bone marrow. So sarcoid could be on. Of course, connective tissue disorder, these three involvement, always think of connective tissue, neuropathy, thrombophlebitis, anti-lupus, anti-coagulant. पूरा सब कुछ कर लिया, मसल सब कुछ कर लिया, बट ल्यूपस एंटीकोगुलेंट नहीं दिया नहीं, ये तो आप पैथोलॉजिस्ट से बताएंगे. So not given to me. What stroke हो सकता है, vascular disease है, but lupus anticoagulant not done. ANCA was there, because ANCA was done twice, and so that is malignancy. Again, lymphoma with very well described cutaneous lesions in lymphoma, and thrombophlebitis has also been described. Myositis described. Bone uptake. Remember, PET-CT had two important events. One was the muscle, second was the bone uptake, diffuse bone uptake. That is why they did bone biopsy. Why was the bone biopsy done? Just to ensure that we don't miss lymphoma or neuropathies when. Now, vasculitis. This is a condition which is always kept in CPC. I don't know whether it is here or not, but vasculitis, I did 4 CPCs, 2 of them turned out to be vasculitis. So this is a very classical photograph. We have a large vessel. Taka issues is always younger and giant cell elderly. Simple. 60 साल से ज़्यादा 20-30 साल. And here we have medium cell. Polyarthritis, middle aged, Kawasaki's, बच्चे. Cryoglobulinemia, small cell vasculitis, anti-GBM, and then we have ANCA association. I was told ANCA दोनों तरीके से किया. ELISA as well as the immunofluorescence. So this should be at least out. This is a huge list. Again, I'm telling you, they can have single vessel. They can have what is known as lupus, all sorts of vasculitis. Then we have vessels, and then we have the final. So vessels, again a very important young male. Turkey में तो बहुत ज़्यादा होता है. उस एरिया में वो जो क्या कहते हैं that belt is there. But more important in India, I have seen 3 patients. One accelerated young girl coming to Islamic, very common, migraine, this, that, and she turned out. Second is, of course, what is important is ocular, oral and genital ulcers. That is the hallmark. One of the diagnostic criteria is oral ulcers. अगर ये छुपा लिया, again no examination, no mouth examination done. But this is a very important clue, which unfortunately were not there, both here as well as here. But patient did have skin lesions. Patient, of course, pathology test, again a very important clue. वो जो अभी बताया ना skin हुआ और उसकी बढ़ गई. So that is also what is known as abnormal pathology test. I don't have time to teach you all this, but more important, there are various varieties of that. And finally, polyarteritis. अब polyarteritis में क्या elderly middle aged में होता है, but this patient was slightly younger. Necrotizing vasculitis is one of the hallmark, and the patient has normally lesions. But patient कब आया? November में. अब हो गया April. The presentation was vascular, but more venous. And the patient can have skin involvement, digital gangrene skin infarction, painful subcutaneous nodules, myalgia and myelogiosis, myelogiosis. I don't know how many of you have heard this term, but arterial hypertension, जो छुपा हुआ था जिसमें this patient did not have hypertension. Why? Only one reading. You have to have 2 or 3 readings. But definitely this person could be having arterial hypertension. So the patient had skin involvement, myalgia, hypertension, peripheral neuropathy. Though classically mononeuritis multiplex, but polyneuropathy can also be there. And finally, renal involvement bilkul nahi hai. And that can be a case, but sometimes there are 2 varieties. Now they have microscopic angiitis, which is more renal involvement, not there. So I don't know. Well, this is what I have mentioned why it could be. Now, as I said, I am not going to leave you with any final diagnosis, but possibilities. See, no person can claim to be a possibilities can be, and I'm keeping it quite open. Vasculitis, medium vessel, probably fits into. He's not a right person to come with at the age of 20, but he had an aggressive disease. He had a venous involvement. He had a painful nodular lesion. He did have, other thrombophlebitis and sarcoid vasculitis with myositis is well known, and I have kept that as second. And finally, I did have, because they did a bone biopsy. Now I have to justify. AIIMS doing a bone marrow and a lympho biopsy. कुछ ना कुछ तो होगा. So a possibility that can only be diagnosed, of course, apart from sarcoid, lymphoma with vasculitis and myositis. So these were there. So my primary thing is vasculitis. अब वो अंदर क्या निकलेगा वो तो पैथोलॉजिस्ट जानते हैं या पेशेंट खुद जानता है. Otherwise no one can know. Clinicians are always relying on. After 1 month and 5 biopsies, thank you very much for bringing it here to educate us. Thank you very much, AIIMS, for allowing me to present. I again apologize for my very simple presentation. The reason is that I have become supposed to be a simpler person now, so I have to show that I am simple. Thank you very much. I hope I'm not exceeding.
Thank you, sir, for that very engaging and interesting discussion. Are there any comments from the group, from the house, any alternate diagnosis, any questions to sir?
If we don't have to treat us, we would not have come. So, but bone uptake, increased bone uptake can be one of the part of it. And failure bone biopsy and everything.
I invite the clinical unit to please.
So, thank you, sir. It was indeed, I will say, given the circumstances you were in, you have put excellent show. That was expected from you. I have been a student, so I know his approach and the simple way he has been teaching us about how to approach a complex case. And I will say you have done fair justice to this case. So this we have already seen. This problem of the patient started in November 2021, and the first time he sought our guidance, our help was in April 2022, and it took us almost 6 to 7 weeks to actually finalize the diagnosis. So of course, I will give credit to sir to almost reach the diagnosis. And once we had some suspicion in mind, we sought the help of pathologists. Ultimately, they are the ones who come to our rescue. So, but before that, of course, we had support of rheumatology department, nuclear medicine department, radiology department, dermatology department. So many departments were involved to reach the diagnosis. So I will not waste time and call pathologist for demystifying this condition, and then I will take on what we did after that and how the patient is doing.
Going on to this, from in the Department of Pathology, we received 3 biopsies. This was as soon as the patient presented to the medicine department, where he had cheek swellings and left mandibular swellings. 3 biopsies were received: a cheek swelling, 1 from the arm and 1 from the leg, followed by a bone marrow biopsy. So during the time of these biopsies, we can see the clinical diagnosis that they had in mind was cellulitis with thrombophlebitis, solid organ malignancy, hematological malignancy, and cutaneous lymphomas. So going through these biopsies one by one, this was the first one of the first biopsies, the cheek biopsy. Here you can see this is the scanner view of the skin, showing a very beautiful skin biopsy, which is very adequate, showing the superficial dermis, the mid dermis, as well as the subcutis. Now, even in this biopsy, we can see that the superficial dermis is relatively normal. There doesn't seem to be much going on, whereas the inflammatory infiltrate or some darkening is basically seen in the mid dermis, as well as there is something going on in the subcutis as well. So this is a higher magnification of the superficial dermis. Here you can see the epidermis is normal. The superficial dermis, which primarily contains the capillaries and the post-capillary venules, they are showing some amount of perivascular inflammation. However, there is no endothelial damage, no RBC extravasation. These are the lymphatics here, which we can see filled with lymph. Again, there is no inflammation, no atypical cells or any atypical lymphoid cells or malignant cells in the superficial dermis. There is very minimal dermal fibrosis. Coming to the subcutis, here again, we are not seeing much of inflammation, but what we are seeing are a lot of foamy histiocytes indicating remote fat necrosis, which means there has been fat necrosis, although currently there is no active necrosis going on or inflammation. And now coming to the mid dermis, which is where we saw a lot of inflammatory infiltrate. You can see that there is a lot of inflammation that is happening here, and possibly some inflammation around some of these vessels, which are some of the medium-sized vessels. So this is a higher magnification of these areas where it looked like some vessels were involved, and this is a small, medium-sized vessel. We are not exactly sure whether it's a vein or an artery. You can see that the entire vessel is thrombosed with neutrophilic debris within it, and this is surrounded by an inflammatory infiltrate composed of neutrophils, lymphocytes, and plasma cells. There are no eosinophils. This is the VBG or the VBG stain, which is used to highlight elastic lamina. So we use this stain to differentiate between a vein and an artery, and here we don't see much of an elastic lamina. Of course, the artery or a vein is completely destroyed. We are really not sure. These are some of the other vessels that we found in this biopsy. Again, here this seems to be a medium-sized vessel, completely destroyed with some recanalization being attempted. Another vessel here, this is of course a medium vessel, medium-sized muscular artery. We can make out the muscle layer as well as the endothelium. There are some inflammatory cells going into the muscle, but we are not seeing any fibrin or thrombosis. So this may qualify for vasculitis, but we are not seeing any definite evidence of active vasculitis. This is another vessel, again in the subcutis, showing recanalization happening and some perivascular inflammation and fibrosis. Coming on to the arm biopsy, again here this is the scanner view showing that the epidermis and the superficial dermis is fairly preserved. We are seeing some pigment incontinence and some fibrosis. And again, in the majority pathology seems to be centered in the deep dermis as well as in the subcutis. Now, again, a higher power of the superficial dermis showing some fibrosis. The venules and the capillaries are perfectly fine. And this is the deep dermis and the subcutis. Again, here as compared to the cheek biopsy, there is a lot more of fat necrosis that you can see both in septal as well as lobular location. And here again, we can see that the vessels are standing out prominently with a lot of perivascular inflammation. This is a higher view to show the foamy macrophages which are present in the areas of fat necrosis. And these are again medium-sized muscular arteries or small muscular arteries, again showing some inflammation in the wall and some endothelial damage. This is again an artery which is now in fact not recognizable enough with a lot of inflammation, and here what we see are hemosiderin deposits indicating some evidence of remote vasculitis, although currently it is not showing fibrin. This is an adjacent vein and a capillary which look fairly normal. Coming on to the third biopsy received at the same time, this was from the leg swelling, and here you can see, unlike the previous two, here the epidermis is completely ulcerated. So all of this was done. They are part of the same biopsies. A, B, C. They were done at the same time. So we gave a composite report. So this was a third biopsy received in the same form, and this here we can see that the epidermis is completely sloughed off and ulcerated. However, the superficial dermis is only showing, does not show a significant inflammation. And again, the inflammation is primarily in the subcutis and in the deep dermis. And here on higher magnification, this is the higher magnification superficial dermis showing fibrosis. Whereas in the deep dermis, here we are seeing much more active inflammation. And here we can clearly make out that these medium-sized vessels are all showing active inflammation and fibrin deposition. Another view of the same. And this is the higher power of this medium-sized vessel. We can make out the smooth muscles here. This is the endothelium, which is intima is completely destroyed, and we can see fibrinous deposits. And again, the inflammatory infiltrate is composed of neutrophils, lymphocytes, and plasma cells. There are no eosinophils. Another vessel where the media can be better made out, and again showing damage to the intima and presence of fibrin. These are some of the other vessels which are present deeper in the subcutis, again showing evidence of active vasculitis with fibrinous necrosis. This is the empty stain, which again highlights these vessels. These are medium-sized muscular arteries showing periadventitial fibrosis and fibrin deposition within the surface, which is highlighted here in red. And this is the VBG stain, which is now going to tell us whether it's a vein or an artery. And you can see here that it has a nice internal elastic lamina, which is partly disrupted, showing that this is actually a muscular artery. Some the other two vessels did not, the internal elastic lamina was completely destroyed. However, they did show an external elastic lamina, once again proving that these, what we were looking at, are actually muscular arteries. This is a CD34 stain showing endothelium, which is damaged with some recanalization happening. So, based on these three biopsies received at the same time, what were the findings were that the small arteries were involved. At least in the third biopsy, we found transmural necrotizing inflammation with destroyed elastic lamina and thrombosis, which is diagnostic of active vasculitis. There was a panniculitis, although it was largely limited to the areas around the thrombosed arteries. The inflammatory infiltrate was composed of lymphocytes, plasma cells, and neutrophils, and there was no significant venular, lymphatic, or capillary involvement. The clinical differential diagnosis, which included thrombophlebitis, lymphangitis, solid organ malignancy, or cutaneous lymphomas, were largely excluded at this point, and we landed on a diagnosis of arteritis. A bone marrow biopsy was also received around the same time, and this showed a relatively normal bone marrow with hematopoietic elements of all three series and with normal cellularity. So coming on to arteritis, in general, pathologists, we classify the arteritis based on the type of vessels that is involved, which could range from large elastic arteries, medium to small muscular arteries, arterioles, capillaries, post-capillary venules, lymphatics, veins, and large elastic veins. So in general, small vessel vasculitis will involve venules, post-capillary venules, and capillaries and arterioles, which are usually present in the superficial dermis in skin biopsies. Small muscular arteries are usually present at the dermo-subcutis junction and in the subcutis, as well as medium muscular arteries, that are named arteries which are present in our body other than the aorta and its branches. And then these are the medium vessel vasculitis, and the large vessel vasculitis are those that involve aorta and its branches. And for a pathologist, we differentiate between these vessels based on the presence of smooth muscle, presence of internal external elastic lamina, and the distribution of the elastic lamina per se. So in this case, since there was cutaneous involvement, both small vessel vasculitis as well as medium vessel vasculitis can present with cutaneous involvement. When the cutaneous post-capillary venules and capillaries are involved, patient usually present with palpable purpura, whereas cutaneous small arteries, muscular arteries, when they involve, patient present with skin ulcers and nail fold infarct. And here the biopsy was primarily showing a medium vessel vasculitis with panniculitis. So a diagnosis of medium vessel cutaneous vasculitis with panniculitis was offered on these biopsies. Following this, the clinical team, they had to do further workup, first of all, to decide whether this was primary or secondary due to other underlying causes. Now, the causes of medium vessel vasculitis involving skin could be primary vasculitis, of which polyarteritis nodosa is the prototype. It shows a mixed infiltrate of vessel wall with surrounding limited panniculitis. The lesions tend to be segmental, usually happening at the branching point of arteries and in various stages of evolution, which was something that we did observe in our patient. Every biopsy from different sides, whereas the cheek biopsy was quiescent, the arm biopsy did show some inflammation, but it was a leg biopsy that was active. So these sort of variable stages of evolution are described in polyarteritis nodosa. But still, it is very important to rule out secondary vasculitis, as Sir said. Usually this terminology, histopathologic terminology that we use would be nodular vasculitis, which is a pattern of lobular panniculitis with vasculitis, which was observed in this case. And this can be associated with various conditions, particularly erythema induratum, a number of infections, granulomatous infections, rheumatoid arthritis. as well as inflammatory diseases including SLE, Sjogren's, sarcoidosis, infectious diseases like hepatitis B, C, HIV, and neoplasia, and drugs. And of course, the clinical team did an extensive workup in order to rule out all of these. Autoimmune antibody profiles were negative, ACE levels were normal, tumor markers were negative, blood cultures and other infectious workup were negative. The only things that came out positive were Leptospira IgM and CMV DNA PCR. Usually, Leptospira infection causes small vessel type of vasculitis or a lymphocytic vasculitis pattern, which was not seen in this patient, and there was no viral cytopathic effect seen for CMV. We did perform a lot of immunostains, special stains on the skin biopsy to rule out organisms, which include gram stain, silver stain, acid pass stain, periodic acid shift, GIMSA, all of which turned out to be negative. A hepatitis B HS antigen performed, IHC performed on the skin biopsy was also negative. During this time, when around 1 month after the first biopsies, we received a liver biopsy because during this time, patient was having some unexplained hepatomegaly with Leptospira IgM positive. So there was a liver biopsy done with the suspicion of secondary systemic vasculitis, and this liver biopsy again was a normal study. There was one very acute perivascular, inflammation around the central veins and the portal tracts. HbS-HAG was negative. There was no fibrosis and no activity or chronicity that was seen. So that finally brought us to diagnosis of maybe we are looking at a primary vasculitis. So the classification of primary vasculitis is usually based on vessel size, large vessel vasculitis, medium vessel, and small vessel vasculitis. Although on histopathology, this was a medium vessel vasculitis. Sometimes small vessel vasculitis can also secondarily involve medium vessel vasculitis. It's essential to rule out these conditions as well. And on the clinical and laboratory workup, vascular-related autoantibodies, P ANCA, C ANCA, rheumatoid factor were negative. Immunofluorescence was performed on the patient's skin biopsy to look for whether there were cryoglobin deposits, IgA deposits, and all of these were negative. In fact, there were no immune complex deposition. The only thing that was positive was fibrinogen or fibrin, and that also came positive only in the small arteries of the mid-dermis, whereas in the superficial capillaries and PCVs, they were completely negative. So that brought us to a final diagnosis of polyarteritis nodosa. Polyarteritis nodosa is a primary systemic vasculitis characterized by necrotizing inflammation involving medium-sized and small vessels. It shows usually multi-system involvement, most commonly skin, peripheral nerves because of the involvement of the epineural arteries, gut where the mesenteric arteries are involved, kidney where the renal arteries are involved, resulting in renal hypertension, and lungs are classically spared. The American College of Rheumatology criteria for diagnosis of PAN, our patient met most of these criteria. However, there is a separate entity known as cutaneous limited. We need 3 out of 10, so yes. And cutaneous vasculitis is a subtype of systemic PAN where the vasculitis is limited to skin with similar histopathology as classical PAN. And patient does not have internal organ lesions, although fever, arthralgia, neuropathy, and myalgia can occur in up to 1/3 of cases. And the importance of differentiating systemic or classic PAN from cutaneous PAN is that cutaneous PAN may have a better prognosis, although there are some data suggesting that many may progress onto classical PAN in certain cases. So again, now to differentiate whether this was just classic systemic involvement of cutaneous, patient underwent radiological and clinical workup. 2D echo was normal, bilateral renal artery Doppler was normal, CT angiogram was normal, bilateral upper limb arterial Doppler was normal. The only things were nerve conduction studies did show a sensory motor polyneuropathy involving all 4 limbs, and ultrasound and PET CT muscle showed some uptake within the muscle, suggesting myositis of forearm and calf muscle. Now, although generally there is no specific criteria to differentiate cutaneous PAN from systemic PAN, where systemic PAN is made whenever there are cutaneous plus systemic involvement, there are certain groups that have offered certain diagnostic criteria where when in the presence of fever, hypertension, and certain other systemic features, a diagnosis of cutaneous PAN is excluded. One of these two, peripheral neuropathy and arthralgia and myalgia, was present in our patient, but however, they were not present outside the affected skin lesions. Wherever he had skin lesions, that's where he had the arthritis and myositis. Still, they did perform a muscle biopsy at this time with the diagnosis of query cutaneous PAN and query myositis. So this is the frozen section of the muscle, which on low power looks relatively normal again. There is there's no endomysial, perimysial inflammation or some fibrosis. This is the formalin, PIC, paraffin embedded sections. What I would like to highlight here, these are the lymphatics, veins and the arteries, and all of them look absolutely fine. There's no evidence of arteritis or vasculitis within the muscle biopsy. There was some scattered foci of inflammation, which you can see here on the higher magnification. This was perivascular lymphocytic infiltrate and some endomysial infiltrate. But again, the vessels were all absolutely normal, and except for some scattered inflammation, we did not see anything. This is the frozen section. Again, there is no perifascicular atrophy, no degenerating fibers, no perifascial inflammation, which are usual classical features of dermatomyositis. Those were not there. And very occasional degenerating fibers were, however, seen, especially deep within the fascicle. And inflammatory panel IHC is usually performed in all muscle biopsies. And surprisingly, what we found was that in this patient, MHC class 1 was upregulated diffusely in all the muscle fibers. It was there both on the sarcolemma as well as some of the fibers also showed cytoplasmic expression of MHC class 1, which is a very specific marker for inflammatory myositis. And however, anti-MHC class 2, which also is upregulated inflammatory myositis, was not upregulated. This could happen because of the steroid treatment or other reasons. In addition, patient also had MAC deposits. MAC indicates membrane-attank complex, which is the complement C5b29 deposits were seen in the endomysial capillaries. Now, MHC class 1 upregulation and MAC deposits are again diagnostic features or supportive features for the diagnosis of dermatomyositis. And so this raised the question of whether we are actually looking at a dermatomyositis. But although the histopathological criteria, which is perifascicular atrophy, inflammation, they're all missing. Because of this, myositis-specific serum autoantibody profile was done, which was negative for all of these antibodies, including the antibodies which are usually elevated in dermatomyositis. So the summary findings from our muscle biopsy was that there was no evidence of active or remote vasculitis, which is why the muscle biopsy was done. But instead, we have seen occasional degenerating fibers and upregulated MHC class 1 and granular MAC deposits, raising suspicion for dermatomyositis. So then we did a literature review, and what we found was that MAC deposits in MHC class 1 upregulation, although said to be classical for dermatomyositis, can sometimes be seen in other autoimmune diseases as well. And this is a study performed by Brakinski where they show that non-dermatomyositis cases can also show MAC deposits, and such conditions include polyneuropathies, mononeuritis multiplex, ANCA-related vasculitis, and in their series they had at least 2 documented cases of PAN. And there are certain features that helps to differentiate between DM cases and non-DM cases, which includes, unlike DM, we don't see perifascicular atrophy, and the MAC deposits tend to be diffusely distributed within the fascicle, unlike in dermatomyositis, where the MAC deposits are usually in a perifascicular location. And DM-related serum autoantibodies are negative, and none of these patients whom they followed, these non-DM patients, none of them progressed to dermatomyositis. So it's likely that these 2 findings are part of the spectrum of autoimmune PAN itself. So that brought us to the final pathological diagnosis, clinico-pathological diagnosis after extensive workup as medium vessel vasculitis compatible cutaneous polyarteritis nodosa, lack of systemic vessel involvement, and neuropathy and myositis limited to the region of skin involvement. Thanks. I must congratulate you for just landing on it. But you made it. It was your first DD.
The CPK was not elevated much. It was just borderline. Yeah. Yes, sir. So that's why I said that whenever you have doubt, you always have to seek question from the patient. You have to look for clinical clue. We have intentionally omitted few points just to, not to say test, sir, but of course how you approach a case that has been exemplified. Sir has specifically asked for what was the sequential BP reading, what was the ocular examination, what was the oral examination, just to rule out basics and other conditions. Apart from that, of course, what was the CPK level. So all these things, sir had reached us to find out what was those situations. So we always have to seek and ask, go back to our basics, just to rule in or rule out a particular diagnosis. So again, yes, so you can finish.
So I'll just a few slides about discussion on polyarteritis nodosa. This was first described in 1842 where it was called periarteritis nodosa. Nodosa indicating the presence of aneurysms, and this was later renamed as polyarteritis nodosa. In 1931, PAN limited to the skin was recognized, and in 1970, an association with HBV was recognized, although currently this association is reduced due to vaccination. Unlike other vasculitis, PAN is not well understood as there are no specific serological tests that are available, and it is an extremely rare disease with incidence 0 to 1.6 cases per million. The classic PAN is a multi-system disorder, life-threatening, more common in 45 to 35 years with a male preponderance. Pediatric PAN cases are rare but documented. Again, the exact pathophysiology is unclear. It could be due to inflammation, direct endothelial injury, presence of pro-inflammatory cytokines or antibodies, which such as the anti-endothelial cell antibodies, which are seen in PAN as well as in other vasculitis, and treatment is usually steroids and immunosuppression. The 5-year survival rate for untreated PAN is 13%, but the survival has been improving in recent years due to immunosuppression. And there are two clinical variants which are important to recognize, one being HBV associated PAN, which needs to be treated by antiviral, and the other is the cutaneous PAN. Cutaneous PAN is rarer than classic PAN. Only 4% of PAN cases are meet criteria for cutaneous, often present in childhood and a slightly younger age group. Again, the pathophysiology is not well understood, possibly results from a complex interaction, usually triggered by infections, and in recent years, genetic defects, particularly autosomal recessive mutations in CECR1 gene resulting in adenosine deaminase enzyme deficiency has been identified. Because of this enzyme deficiency, patient has uncontrolled activity of the neutrophils which cause endothelial cell damage. In addition, they also have some degree of mild immunodeficiency. And of course, this has a very highly varied phenotype and may range from benign self-limiting to really serious cases. Treatment, again, there are no established guidelines. Dr. Sir will talk more about the treatment. The outcome, it has a chronic course, months to years with exacerbation and remission. And neurological symptoms and muscle aches may resolve over a matter of months. Skin lesions may take long.
Thank you. So, like Sir said, Ramban for all this type of disorder is immunosuppression, but at the same time, when the patient presented, the counts were raised. The patient has gangrene, developing gangrene, which could have been infected. So we were not sure whether we should start with immunosuppression right away or should we wait for the final diagnosis. But since the patient was deteriorating, we had to take a clinical decision, and we had a suspicion of cutaneous PAN. So we started, because since the gangrenous part was increasing, so we labeled it as a severe form of cutaneous PAN, and we started with oral glucocorticosteroids, and we started with Isolon 50 milligram based on the weight basis. But as the disease progressed, and over last 6 months, the patient had 5 admissions. This is the 5th admission with which he is with us. So we had to gradually step up the immunosuppressive strategy, and in fact, he has received 4 doses of methylprednisolone pulse. Apart from that, he has received 3 cycles of cyclophos, and recently we had to switch to biologics, and we have given infliximab, and the last one was tocilizumab. In spite of that, the patient's situation has been waxing and waning, and at the moment, this is the summary of the response which he had with the various immunosuppressive regime which we used. Initially, he showed some response with methylpred pulse along with cyclophosphamide. Till second pulse, he was more or less doing fine. But after that, his improvement in skin lesions become static, and in fact, with subsequent admissions, his lesions progress. And that's why we had to rethink whether what we are doing is correct or not. But once we gave tocilizumab, the recent development has been that he has developed multiple blisters in bilateral lower limbs, which started post-discharge. And based on that, we have to defer the further immunosuppressive therapy which we were planning. He was started on broad-spectrum antibiotic along with regular dressing. Now, at the moment, the patient is stable as far as infection is concerned, but there is persistence of blisters in his lower limbs. So, is there any other possibility? Are we missing something? But again, like Sir said, we are using Ramban. Irrespective of what other pathologies which might be this patient might be having, could have been tackled with whatever immunosuppressive strategy we are seeing. So we had kept a possibility of type 1 interferonopathies, but again, the clinical features of, say, adult onset SAVI, which usually the patient is presents in infancy with interstitial lung disease. These features were missing, or a cardiac Goiter syndrome where neuronal involvement may be there, which was missing. We did enzymatic analysis for ADA2 deficiency, which was negative. So again, we in a way rule out the other two problem. So did we start all these fancy drugs on our whims and fancies? So I will say no. There was a logical thinking about whatever step up we have done with our immunosuppression. Since there is lack of large controlled trials in idiopathic pan to have an informed practice, of course, we have to be careful about whatever we are using. So first set of guidelines was recently published by ACR in 2021. But again, most recommendations being conditional and based on low to very low quality of evidence, we are not very confident about what should be used. And these guidelines have excluded patients with isolated cutaneous pan, which our patient has, and did not address the use of biologic agents if no response to steroid plus cyclophosphamide happens. So where are we? What should we do? So this is the general principle of how to use active pan. What is important to note that these all treatment options are conditional recommendations. So whether the patient is going into clinical remission or not going into clinical remission, it's based on very low quality of evidence. Again, use of biologic has not been addressed in these particular guidelines. So whenever we have to take a call when evidence is missing, then of course we have to take a call on patient's values and preference. And of course the patient's father was more in favor of using cyclophosphamide because that was one drug which showed response, to which the patient showed response initially. Then again, clinical experience. So we borrowed data from other vasculitis. We sought opinion from dermatology and of course rheumatology department. And based on whatever data we could get hold of, we tried to use those information to tackle this particular patient. So knowledge of disease pathomechanism and targeting major disease driver is again important. But again, the exact pathomechanism of PAN is still something which we are grappling with. And this involves multiple redundant cytokine pathways, which in case if we are targeting one particular pathway, the other pathway may get activated and actually cause disease to propagate. So this is what we are saying. If we use glucocorticoid and cyclophosphamide to target one particular pathway, there could still be other pathways which might be propagating this disease. So we sequentially added those drugs so that we could target different pathways to see if the response this patient gets or not. So the rationale of TNF-alpha inhibition and other has been based on whatever case reports and case series we could get hold of. So yes, sir. But anyway, we have ruled out this particular thing. So yes. So again, serum IL-6 level correlated with disease activity, that has been shown, and that was the reason based on which we tried tocilizumab as well. But the patient, again, we have to see how he responds to the particular therapy. Again, manifestation of cutaneous pan may be similar to type 1 interferonopathies. Interferon signaling is mediated through activation of JAK-STAT pathway, which can be effectively hijacked by JAK inhibitors. Again, we are thinking if we want to give this or not. So basically, we are stuck with a patient whose disease is progressing in spite of using whatever possible therapies we can offer to him as far as immunosuppression is concerned. Yes, sir. So once the patient's infection is controlled, we are planning to target this B-cell depletion strategy by using rituximab, and we hope the patient shows some response. So again, based on whatever we have, the final diagnosis which we have kept at the moment is acute severe refractory cutaneous polyarthritis nodosa with distal peripheral gangrene with secondary infection. Active because the disease is still active, severe because it's involving different parts, limbs, and refractory because we have tried various immunosuppressive strategy, but the patient is not showing the desired improvement. So again, a lot of departments were involved. And of course, thank you to Department of Dermatology as well. Somehow the name is missing. So, any comments from the house?
My compliments to you, sir, for presenting the diagnosis. And also showing us after the CPC. And also letting us know when a liver biopsy will have a diagnosis, then it will not, which was I think proven by this very biopsy. Thank you, sir.
So the question one on YouTube, is there any role of plasmapheresis in this particular condition?
You said you already done so many things. The Prof was helpful to you have to globally present a video. You can answer.
Yes, sir. So again, plasmapheresis was thought of. In fact, the patient received one cycle of plasmapheresis initially, but since it has no role, it was decided against continuing with plasmapheresis. Fine.
I think it was found shade processing. It's made the science. Thank you.